Weiss. I'm a lung cancer doctor at UNC, lung cancer researcher, an advocate and former board member with Lung Cancer Initiative. It's my pleasure to talk to you today about extensive stage small cell lung cancer. So lung cancer is one of the most historically stigmatized cancers. This comes in part from the association with smoking, but particularly within the healthcare community, where this is also very real. It also comes from therapeutic nihilism, from limitations in the efficacy of our therapies, or at least perceptions about limited efficacy of our therapies. We've had wonderful advances against non-small cell lung cancer in recent years. Targeted therapy against targets like EGFR, then ALK, NTRK, ROS1, RET, most recently KRAS, have been inspiring in offering many of our patients, particularly some of our non-smoking patients, therapies that are less toxic, more effective, and that demedicalize life. Immunotherapy has offered us durable control and even occasionally cure for some of our non-small cell patients. In parallel with celebrating these advances, and in pushing further to advance them yet further, in parallel we need to stop and reflect as well on those within our fold who have been left behind. And here I'm talking about small cell lung cancer. While we have had advances against small cell lung cancer, they have been modest compared to the advances against non-small cell lung cancer, and the stigmatization of the small cell patient for the similar reasons that non-small cell was historically stigmatized remain. And so in parallel with celebrating our wonderful advances against non-small cell, I'm happy to take questions about non-small cell from those who have it. I'd like us to take a very short amount of time, just half an hour or 3 10-minute talks, and focus exclusively on small cell lung cancer. So small cell lung cancer is an extremely aggressive cancer. It likes to present centrally in the chest, where it can cause a lot of suffering from clipping off the central arteries and the central airways. It's easy to identify under a microscope because it's this crazy aggressive small round blue cell tumor. Our therapeutics have a high chance of working. When we give chemo for small cell, we expect rapid, dramatic response. Unfortunately, it also tends not to last. Now, until the data I'm going to show you on the next slide, we went about 50 years with no advances against survival in small cell. Think about that for just a second. Think about what was going on 50 years ago and how long that was. So the first regimen to prove efficacy against extensive stage small cell was the combination CAV regimen, which at this point for most of us, maybe not all, is a historic footnote. But it was replaced by platinum etoposide, not because of an improvement in survival, but because it was less toxic and easier to give, more convenient for patient and doctor. But as the curves at the right show you, it actually resulted in no survival improvement at all. The first survival improvement in that 50 or so years was the addition of PD-L1 immunotherapy to standard chemotherapy. What you're looking at here is the design of the Empower 133 study. What Empower did, glad I have a pointer. The only people who love laser pointers more than cats are academics. So what Empower 133 did was, this is a little serious up front, right? So you gotta lighten it a little. So what it did was randomize patients with extensive stage small cell lung cancer to the then standard of care, which is platinum etoposide plus placebo, right? No one being denied standard of care plus placebo, versus that same standard of care plus the then experimental PD-L1 inhibitor, atezolizumab. And whatever was added via placebo or atezolizumab was continued as maintenance therapy. And it's a delight to show you this first major advance. Right here we have a roughly 24% improvement in survival for extensive stage small cell lung cancer. A critical question that always must be asked when we add another agent to standard of care is, okay, you've given me a survival advantage, but at what cost to toxicity? The answer was not much. Of course, we had the immune-related adverse events that we always have when we add an immune-stimulating drug. But there had been a fear that it would be much worse in small cell lung cancer because small cell has all these paraneoplastic syndromes, these autoimmune events that the cancer causes. And we really didn't see that. it looked just like immunotherapy had looked historically. And so this was reassuring data. This study was essentially replicated by the Caspian study, which did mostly the same thing: standard of care chemotherapy versus standard of care chemotherapy plus a different PD-L1 inhibitor that happens to be called durvalumab. There was a third arm in this study that gave the weak CTLA-4 inhibitor tremelimumab, but since it was not in advance, I'm going to put it aside for the moment and focus on what actually changed care. And here, I thank whoever color-coded these curves that they made Carolina blue the winning arm. The unnecessary drug that did nothing here in 2 blue. And here we are at G1. I apologize that I can color-code these, that orange was the losing standard of care arm at all. And so if these curves look at all familiar, this at all looks like the good people at AstraZeneca photocopied Genentech Roche's curve, it's because they are essentially the same curve. That's because the two agents are more similar than different, and both companies did their studies very well. They were well, ethically, appropriately run studies. And so this study replicated the finding and proved the idea that PD-L1 inhibition really does improve survival in small cell. And as we get more and more updated data on both of these studies, and I apologize to my good friends from Genentech, it happens to be the AZ data that I had the easiest access to. As we get 3-year update here, look at the tail. That's 3-year survival in small cell. 2 really important points here to make. The optimistic one: more than 17% of patients alive and counting at 3+ years in extensive stage small cell. Those of us who've been doing this for a long time know that that is unprecedented, that's inspirational. But anyone with common sense can say, hey, wait a minute, that's only 17 or 18%. Get back to work on the research. And I think both are true in parallel, right? This is inspirational. It also shows us the unmet need that needs to be fulfilled. Safety data were, again, nearly identical. So I mentioned earlier that our therapeutics in frontline tend to work really well, and then unfortunately relapse is rapid, which leads to the unmet need for next line therapy. Historically, the standard of care drug was a drug called topotecan. Topotecan may be the most hated. In fact, I see Tammy's respiratory rate going up just from the mention of the name topotecan. I gave it for 15 years also. It is the most hated drug in thoracic oncology because it is bad tasting and more filling. It is not that effective, and it's really toxic, right? It has both of the bad characteristics. Enter lurbinectedin. Lurbinectedin is a selective inhibitor of transcription. In practice, it looks more like a new chemotherapy drug that was studied in next-line small cell, and that looks better than topotecan. In the omnipresent but forbidden cross-trial comparison, which is to say we don't have a trial of topo versus lurbi. We have the topo data sets, we have the lurbi data sets, we have our topo experience and our lurbi experience, and I think it's easy to say that it's less toxic and more effective than topo. This is a very, very busy table, so I've highlighted for you what's important here. Response in oncology is defined as an at least 30% shrinkage by a one-dimensional messed up system called RECIST. Do people with 29 and 31% shrinkage really have different outcomes in terms of quality or duration of life? Of course not. But we had to set the bar, or rather, when I was in the sandbox somewhere, those who came before me had to set the bar somewhere to compare drug A to drug B. So it's not a measure of benefit, it's a measure of 30% shrinkage by a messed up system. By that benefit, 35% of patients had response, and this was divided out by chemosensitivity. So in small cell, there's this misnomed, this poorly named term called platinum sensitivity. The idea that patients who go at least 90 days in Europe, or at least 6 months if you're in the US, from the last dose of platinum-containing regimen in frontline until the cancer grows, that you might be able to repeat it. But all of our data sets, both lurbinectedin, several data sets with topotecan, and other drugs, show us that it's really not about platinum, it's about chemosensitivity. Those who benefit from chemo before are more likely to benefit from different chemo later. It's not really uniquely about platinum. This was a study conducted in Spain, which is why the interval here was 90 days, not the 180 that's more commonly used in the US. Truthfully, there's no regression discontinuity at either point, right? It's a continual measure where the longer the benefit, the more likely it is doing something similar will help the patient. But at any rate, for those who had that platinum-free interval of less than 90 days, response rate of 22%, 45% for those with greater chemosensitivity. PFS is a curve that ticks down anytime a patient dies from any cause or their cancer grows. That measure, beyond that, we're learning that I can't line up boxes, or that the MAC stuff didn't transfer. 3.5 months overall, 2.6 for those that were less sensitive, 4.6 that were more. For survival, only 9 months overall, 5 in those who were less chemosensitive, 12 months in those who were more. So again, kind of like the advance in PD-L1, it's inspirational in that it's better than what we had before, but it's not hard to see the massive ongoing unmet need here. Safety here, again, a very toxic chemo-like drug. The most common adverse events were hematologic, as they are with most chemotherapy. I guess appropriate to comment on here at G1 Therapeutics, a company fighting against this, but anemia, low white counts of both kinds, and low platelets. And then the other major events, the things that people feel down here, traditional chemo-type events, fatigue, nausea, decreased appetite, vomiting, diarrhea, right? Unfortunately, events that everyone in this room, practitioner, patient, family, advocate alike, are all too familiar with. So I'm done with the depressing part of my talk, and moving on to the, what I hope will be the more inspirational part, the future advances against efficacy that I think we're seeing. So one of the reasons that we were so slow to make advances against small cell were that our understanding of it biologically was somewhat pathetic. We really didn't understand small cell very well. In recent years, small cell has been subtyped into 4 very discrete groups, and I'm not going to walk through them on this slide, but what you can see graphically here is that they fit 4 very distinct biologic themes. Right? You can see the color coding here is not much overlapping. So there are 4 discrete programmatic themes, probably 4 types of small cell. Does this have any impact for human beings with lung cancer in the year 2022? Absolutely zero, right? Clinicians should not be getting this in clinic. However, do I have a high faith that this will accelerate our ability to make advances against small cell? Yes, I do. And what I'm showing you on the slide before here is that these can be found by IHC, or you need one or 2 slides. So if this becomes clinically applicable, we will be able to bring it to patients cheaply, quickly, and easily. Even at the most expensive commercial lab in IHC, shouldn't cost more than $200 and take more than 3 days, right? So if this does become relevant, it will be easy to quickly translate for people. So this very busy slide reflects the things that I think are coming to a clinic near you most rapidly. We have another new biomarker, which has a cool name, Schluffin-11. Schluffin-11 seems to predict who benefits from the addition of PARP inhibitors to other agents. There are studies with chemo drug, temozolomide, others with immunotherapy that are underway. The immunotherapy one reflected here at the top left. I mention it here because I think it's going to be probably the next one FDA approved. Liposomal irinotecan fits the theme of lurbinectedin, that it'll probably be a little more effective and a little less toxic than what came before, but incremental advance more than dramatic one. But what brings me to the real inspiration here, that I am hopeful will bring us more dramatic gains, or what might be called personalized immunotherapy. So drugs like pembrolizumab, atezolizumab, durvalumab, nivolumab, I like to think of them like gasoline for the fire. If you pour gasoline on a small fire, you rapidly get a bonfire. In this case, an analogy for a dramatic immune response. But if you pour gasoline on an unlit log, all you get is a wet, smelly log. And so what a lot of research is going on is about how to light that fire. And personalized immunotherapy, to me, is one of the most exciting ways to do this. So as a thought experiment, let's imagine that those of us who don't already have lung cancer in the room all develop lung cancer at the same time. And you can give us a spread of lung cancer. Some of us will get the non-small cell subtypes adeno, some will get squamous, some will have small cell. And if you were to sequence all of our tumors and apply advanced bioinformatics to them, looking to see what neoantigens are there, or in slightly plainer English, what foreign-looking stuff that the immune system might react to, you would see 2 things. One is that most of those neoantigens are private and not shared. or in plainer English, most of us would have different stuff for the immune system to potentially recognize. But what you'd also find is you would find a handful of new antigens that were commonly shared, that many of us shared in common. And so for the truly personalized new antigens, the only way to go after that is a personalized vaccine. We're excited to have our PandaVac study opening hopefully by the end of the year. It'll be the first personalized immunotherapy for lung cancer, to my knowledge, in the world. As soon as the FDA will let us do it, hopefully by the end of the year. But for those potentially shared neoantigens, I want to share with you two advances that I find really exciting. The first one, I have absolutely no involvement whatsoever in the research or any conflict of interest of any kind. I'm just incredibly enthusiastic about it. It's a target called DLL3. And I've been sending patients, or trying to send patients, to get on trials elsewhere. So DLL3 is a neoantigen commonly expressed on small cell, perhaps 60+%. And what you're looking at here is the design of tarlatamab. Tarlatamab is a bispecific T-cell engager. What it is a modified antibody. And what the antibody does is it brings DLL3 positive tumor cell together next to a T-cell, an immune T-cell, so that the T-cell kills the cancer cell. And what you're looking at the bottom, that I'll come back to in a moment, is what I spend a lot of time on, something called CAR-T. But first, tarlatamab. So what you're looking at here is data from that Taufika Wanokoko presented at last year's ASCO. This is a waterfall plot. Every patient on this trial, on this phase 1 trial, so different doses, is represented as a bar. Anything north of the 0 line is growth. Anything south of the 0 line is shrinkage. And what Taufik presented was a 20% response rate. But if you dig a little deeper into this data to speculate, you see that the patients who are color-coded at the highest doses have a response rate more like 30+%. This data, currently embargoed, is due to be updated at World Lung in about 2 weeks. I reserve the right to be very wrong. My wife can tell you I do it all the time, but I'm going to speculate, and I have no knowledge of what's actually true. I'm going to speculate that Haas Borgai, when he presents this updated data, is going to show us 30+%, and that it's going to look better than it looked at ASCO. Toxicity-wise, the event that scared the heck out of the medical community was cytokine release syndrome, or CRS. I'm not going to dive into details on that, but I will say that these events were not the big, bad, scary CRS that docs know and hate. These were events managed not only not inpatient in the ICU, not inpatient at all. These were events mostly managed in the infusion room with some oxygen and IV fluid. And so I'm incredibly enthusiastic about seeing that update, and I look forward, Jenny and I were talking about doing an updates for providers soon. I'm sure it'll be available at least to everyone in some format, and I look forward to hopefully being right on that one and sharing with you inspirational data on a lot of them. What we're working on locally, at least at UNC, is CAR-T. So in CAR-T, you take a bunch of T cells out of a patient's own body, and in the lab you change what they target to target what you want them to target, and you take off all the brakes. That's a ridiculously oversimplified explanation of CAR-T. And what we're doing here on our construct, for anyone who has a science background, is disclosed for transparency at the bottom, is our target is GD2. And it turned out that GD2 is not only a small cell target, it's a pan-lung cancer target, right? So from clinical trial design, a major advance from 50 or so years ago is moving from lung cancer to non-small cell versus small cell, to the subtypes of non-small cell, to the driver mutations, right? Subtyping, and we're back to the future, I guess. When we did the preclinical homework on this, we found out that it's common in squamous lung, in squamous non-small cell, in adeno non-small cell, and in small cell. So we broadened the effort. I want to thank all of you for this, because this is a wonderful story of Lung Cancer Initiative. We applied to a Lung Cancer Initiative VEEC co-sponsored grant with the request to give us a small amount of money to do the preclinical homework, the laboratory homework necessary to bring this to people. Thank you for granting that. We conducted that homework. That work was successful, and it resulted in a $2 million award from the Department of Defense. I don't know why they sponsor cancer research, but at any rate, a $2 million award from the Department of Defense to bring this to humans. That protocol is written, and that protocol is at the FDA for what we call IND. And we're hopeful to treat the first person with lung cancer with this agent by the end of the calendar year. So I'm going going to plug right back. You guys made this happen with LCI dollars, but I think it's beyond that. I'm excited about this advance because it's kind of poured my life into this for the last while. It's also a wonderful story about how an advocacy organization can take a small amount of money and leverage it to make something much larger happen later when we not only raise enough money, but use it in a way that can translate to human therapeutics in a very real way. And it's this organization that made that happen. So this is really a three-part talk. I chose to take therapeutic advances as the first part, but I think most of our patients, probably everyone in this room, would endorse that quality of life is at least as important as duration of life. Now, there are many, many aspects to quality of life. Some of them, frankly, are none of my business as a doctor, right? There's emotional quality of life, there's spiritual quality of life. All of these matter a lot. In terms of physical quality of life, there are two major threats to my patients. They're cancer, and we all know small cell is a brutal cancer that hurts people, right? So the therapeutic advances can prevent and roll back some of that suffering. But the other threat is me. Sorry, that wasn't as funny as I thought it'd be. But what I meant by that are the side effects of the agents that practitioners use with good intent to roll back the suffering from cancer. We all know cause brutal side effects of their own. And so the second talk will be from my friend and colleague, Chaely Medley, about advances in supportive care against small cell lung cancer. And we'll end in the third part with an incredibly important talk by Tammy Allred on the nursing perspective on unmet needs in our direction. Jim?
I work with Dr. Weiss and Tammy, and a lot of my role is working with patients to talk about, one, chemo education. Oh, thank you.
How come I didn't get that?
Interject. Discussing chemo education, what are the side effects, what kind of things can you expect, what is your treatment regimen going to look like, how often are you going to be here, and then talking together and figuring out how exactly does this play into your life specifically, and what kind of things do we need to maybe help tailor for you and get certain types of resources in for you. So when I go in with my patients and we're specifically talking about chemo education, the first question they ask me is, well, how sick am I going to be? And I believe that we've had a lot of changes in the most recent years where it's not always like you see in the movies where people are like hugging a bowl in the chemo infusion room, vomiting their brains out, and someone's rubbing their back. Like, certainly I'm sure that happens, unfortunately, but we try to preempt that, certainly. So I always explain, first you're going to get IV steroids in infusion, you're going to be getting IV anti-nausea medication. We're going to be sending you home with 2 different nausea medications with specific instructions on how to take them. And I work very closely with our clinical pharmacists to discuss, how can we optimize these regimens? What are ways that you specifically should be taking this? And then we're using other medications that I always explain kind of falls under the antipsychotic category, but we actually use medications like olanzapine to help with nausea in patients that still have uncontrolled nausea. So generally, I think this is something that we're working to control and people are doing well. But our goal always when we're giving patients chemo, especially with aggressive diseases like small cell, is that we're trying to avoid doing dose reductions and treatment delays. So I try to encourage people as far as the nausea component goes, because I think that we've done a lot there. Other side effects that a lot of people experience would be, specifically with small cell treatments, hair loss. And I try to counsel my patients saying, it's kind of the big thing that announces to the world that you have cancer, because otherwise people might not know it. And so when you walk around suddenly and you've lost your hair and you're wearing this scarf or something's going on, then people might look at you and say, oh, this person has cancer. And suddenly it's a thing, where before maybe it wasn't. And so try to talk a lot about that. Prosthetics for wigs. I know we've discussed cooling caps. We don't use them often, but something that we've been discussing in the past. I'll counsel patients on diarrhea, sometimes constipation, just kind of depending. But we work very closely trying to come up with constipation diarrhea regimens. What specifically do you need? Maybe you don't want to take a lot of medications. Maybe you're kind of over the whole I've taken my nausea medicine, I'm taking my vitamins, I'm getting my chemo, I just don't want to do anything else. And so we're talking about diet, maybe we're talking about drinking lots of water and eating a lot of fiber and, trying to get in some light exercise. Really just trying to look at the patient and you guys holistically, like what all are we working with that's not specifically medical. What did I cover? Nausea, vomiting, diarrhea, hair loss. Other things that maybe aren't as common but still happen, sores in your mouth, what do we need to do about that? How can we work around that? Who can we bring in to help with those kinds of things? And then the thing that I think is mostly concerning for us as clinicians, we're looking at all these other things that are more physical experiences for the patients themselves, but something that's most concerning for us is when we're talking about myelosuppression and talking about your red blood cells, your white blood cells, and your platelets. For us, that's something that very often and very seriously kind of holds back treatment and causes us to have to wait a week for people to recover. And we're kind of reacting as opposed to being preempted in our treatments, or at least we were. And so this is kind of where G1 comes in and trilaciclib. And so we've been using this drug in our clinic with our first-line regimens because we're seeing that with this medication, we're kind of protecting the white blood cells, red blood cells, and the platelets. And so when patients are having this on board, when they come in for their first round of chemo, when they're coming back for subsequent treatments, we're not saying, oh my gosh, your white blood cells are just a touch too low and it's not safe, we need to wait a week. Or we're not saying your anemia is causing you to be so fatigued that you, and short of breath, and maybe chest pain when you're having severe anemia. Like now we suddenly need to have you in infusion getting blood instead, and trying to come up with ways where we're kind of chasing our tail almost. And certainly with platelets, I don't see it as often, but we do have patients where we, have to delay treatment because their platelets are low, like 15, 20, things like that, where we actually are very concerned. And so I think that's where we are having a little bit of relief, saying the other things we've kind of gotten a handle on a little bit, and we've gotten a good team and people that help support us, and we can kind of talk about them and figure out what's going on. But now that we have drugs that are supportive of our treatment regimens, and we can add them on and have more faith that when you come back, we're going to be able to go ahead and do this treatment and carry on and get past those first 4 cycles to move forward with more of our tolerable treatments, I guess. I think it's very hopeful for everybody involved. The other thing that I always educate patients on, especially our extensive stage patients, is atezolizumab. And even with my non-small cell patients, we talk a lot about PD-L1 inhibitors. And so I always explain to people, with atezo, pembro, durvalumab, all the medications Dr. Weiss mentioned, we're always charging up the immune system. And that's the way that the medications are working to fight the cancer. And so in doing so, we can accidentally charge up parts that we don't mean to. And so some of those side effects include dermatitis. So patients might come in with an itchy, red, irritated rash. And generally, it's not something that we have to stop treatment for, but sometimes we do. And so kind of working with patients and discussing how impactful is this to your life? Are you scratching in the middle of the night? Are you avoiding doing certain things because it's so uncomfortable for you? And then tailoring the treatments for that. Looking specifically at their breathing, I ask all my patients, how's your breathing, how's your pain? And so I'm basically trying to rule out anything acute, obviously, infection or anything of that nature, but also pneumonitis, and that's irritation of the lining of the lungs. And patients that have that can come in with rapid worsening shortness of breath, chest tightness, sometimes low-grade fevers. And so these are all things that can limit our treatments and can be very serious. Usually we use steroids to kind of slow down the immune system, but sometimes it requires more than that, and sometimes we have to stop treatment. And so my goal is always to be preempting these things and always talking. I mean, I'm sure some of my patients probably feel like I talk too much because I ask so many questions and I want to know so many things, but it's all in the event or effort to try and make sure we are covering all of our bases. how many times are you having diarrhea? Are you having more than 4 or 5 a day with abdominal pain? Because that's very concerning for colitis. So anyways, all that to say, my major role is making sure that not only are our treatments working, working with Dr. Weiss and making sure that we're on the right path, but also how are you doing physically? What side effects are you experiencing, and how can I optimize your supportive care measures? But also, how are you doing mentally? Do you have emotional support? Are you getting here okay? Is this something that's financially taxing for you? Emotionally taxing? Do we need to get our cancer support center involved so that you have somebody else that you can talk to other than me or Tammy or Dr. Weiss, or maybe even your family and friends who sometimes I'm sure you feel like I've talked their ear off, I need an objective person here. So our goal, is we work as a team. We want everybody to be as successful as possible, and we want to be successful for you and for our lung cancer patients. And so, I think we're hopeful with the way that things are going. I think we have a lot of supportive care things that are keeping us moving in the right direction and further supporting some of the other studies that we have going on. You told me we're doing a lurbinectidine and trilaciclib coming up at UNC. So that's very exciting for us because the side effects of lurbinectidine are very similar to the ones people experience with cisplatin etoposide or carboplatin etoposide, and so that's always kind of a fear of moving into this next regimen. Well, what's going to happen now? Are we gonna not be able to tolerate this regimen for certain supportive care needs that maybe we could get out in front of? And so, anyways, thanks for having me, guys. I thank you for letting me share all of these things with you, and for everybody here that I recognize, thanks for bearing with me while I talk your ear off in clinic and ask you so many personal questions. So anyways, thank you. I give it over to Tammy to talk about some other supportive care patient needs.
Okay, I don't think I need this. So when I was asked to bring up about patient resources and stuff, I was actually redoing our patient education materials that we give out to our patients. So I thought instead of bringing my big binder that I give to patients, I would just make this a just short, sweet couple of pages. And I think everybody's got a copy of it. I tell every patient, the biggest thing is, first and foremost, never Google lung cancer. You will find that they've got these scammers online that will say, well, if you take this witch's tea or mushroom tea and take it, it'll cure your cancer, but it'll tell you it causes liver failure. That actually happened to one of my patients years ago. His wife found it online and said, oh, we'll give him this tea, it's gonna cure him, and he went into liver failure and died. So you just gotta be mindful that there's a lot of good information out there, but there's a lot of false information that could cause really bad harm. So I tell patients, when you're first diagnosed, what does it mean? What is lung cancer? Small cell, non-small cell, adeno, squamous? We need to find out and give you the exact information. So globally looking up lung cancer is not gonna give you the exact information. You need to know what type of cancer you have. And when they come in to just get their first visit with Dr. Weiss, I always talk to them about what does it mean when you're going to get a treatment? What do you do? Where do you go? What does it mean? Are you going to be sick, like Chaely said, holding a bucket while you're getting your chemo? That's far from the truth. Now, when I first got into nursing 30 plus years ago, and I'll leave it there and shut up, Jared. Patients, when they would get their treatments, a lot of times it was in the hospital, and they would lay there in the bed, puking their toenails up while they're getting the treatment. Luckily, we came around and we realized pre-meds make a big difference. So giving patient pre-meds gives them a better quality of life so the treatment can stay in their body and not have ulcers and mouth sores where they can't eat, which lowers their immune system, which causes all these other problems. So when they're coming in to get chemo, they need to know what the infusion center is like. So I tell them you'll have a chair. There's a drop-down TV in some of the chairs, and you've got one family member. Well, before COVID, you could have a family member in there with you. And then bring your goodie bag. Some people think that, unlike Duke, where they couldn't have a tray delivered, UNC, you could have a little can of Campbell's soup, or Bobo soup as I call it. But bring a goodie bag, bring a lunchbox, bring a cooler, because you're going to be there for a while. Bring some of your favorite things, a laptop. If you've got a family member with you and you want to play games, play board games. We did have movies, DVDs a while back. I don't know if they're still being offered for patients now or not. And then the next thing, when you're talking to a patient that's been faced with a new diagnosis of lung cancer, what does quality of life mean to me? Because some patients say, I'm not going through treatment, I'm going to die anyway, I'm just going to walk off. A lot of times, once I talk to them and say, Dr. Weiss has met them, gives them his spiel about their treatment, their disease, I come in, bring it down to a dummy level and say, even though you have this disease, you can fight it. We've got patients that are cured, and Tama Hargraves is our lay navigator. And so I would bring her in and use her as an example and say, this is Tama. Do you think she's a lung cancer patient? Many times they would say no. Well, what is Tama, 16 years? 16-year survivor. So that was a big boost for a lot of patients who didn't want treatment. They would see that, yes, you can be a survivor. Then Tama would talk to them and mentor them through that. So you've got to get rid of all the falsehoods that come up in the community about what lung cancer treatment means. Is there major life events they want to attend? Like, is there going to be a grandbaby or a marriage, or you want to see a child graduate from college? That also encourages them to go through treatment. One thing that a lot of times I've heard this in the community, patients would want to get a second opinion just to be sure they're getting the right treatment, or they hear all the options out there. And I tell patients, if you go to a physician and they refuse to allow you to get a second opinion, you need to get a different doctor. That is your right. If you don't feel comfortable with what they're telling you, find somebody you feel comfortable with. Get a second opinion, third opinion, whatever. Then if you have non-small cell lung cancer, what are your biomarkers? What does biomarkers mean? What does mutation mean? What treatment options are geared towards each one of the mutations? And then encourage patients also to ask, is this a curative treatment, or is this something to control my disease? There again, it goes back to the stage of cancer they are. What are treatment options? Is it oral chemo, radiation, IV chemotherapy, immunotherapy? There's a lot of different options, and a lot of times patients coming in dealing with a diagnosis don't realize that there's a lot of different options out there. What happens if my treatment doesn't work? What if the cancer comes back? So go over the different options. Let them know there's always a clinical trial. Clinical trials are well regulated. I had one patient one time years ago tell me that he didn't want to be a guinea pig because UNC does guinea pigs. So I had to explain that it's strictly regulated. We don't have a doctor that's in the basement locked up in a closet like Dr. Weiss's office who just puts all these chemicals together. It is strictly regulated, and we show that we've got data to support it, and the FDA approves it. So it's not, we're going to be throwing stuff at you. Also, emotional and physical medical support services at the Cancer Center. We've got the Patient and Family Resource Center that has people available to talk, to give education materials down there. We have a wig department. They've got massage therapists. They've got this little pod, or at least before COVID, there's this little pod. It was like a sensory deprivation type thing that you could get into, and it played soothing music to where you could relax. And a lot of times patients who have high anxiety, we get in that and come out and they were like, okay, I can do it now. So there's different options available. We've also have psychological support services, palliative care programs. So it's not just the three of us, we've got a whole team. Where else can patients find support at? LCI is my automatic go-to. The American Cancer Society in some places, and then if the person has a local support program, like the groups that get together, I'm having a brain fart. I know. Okay. Anyway,
Cancer Grace on the internet.
Cancer Grace, yes, that was another one. Cancer Grace is a really good website for patients to go to. It's interactive, correct, where they can ask questions to a provider and get expert opinion. And it's not just lung cancer, but it's all different types of cancers. A lot of patients come in and they've never heard of a navigator. And I had one little man say, well, what do you do? I told him, I said, well, picture cancer as this horrible storm that you're going through. And then you're out there in the ocean and you're going through these waves hitting you, knocking you down. I'm the guiding light. I'm going to get you into land and get you safe. And he was like, oh, okay. So what can you do? So then I go through, I can get you any supportive services, like if you have gas card needs, if you're on oxygen and you're afraid that in the storms that you're going to lose power and you won't have oxygen, we can help get that coordinated with Duke Power or whatever your power agency is. If you have food needs, food insecurities. So I ask a lot of questions to most of my patients and say, you know, what exactly are your needs? After a while, they start calling me. I had one guy, he's one of our young patients. His mother calls me at least on a twice a week basis just to talk. And she said, I hope you don't mind me calling you because I have significant depression and I don't have anybody else to talk to. So anytime you need to talk, you can call me too. And I thought, you know, that was, as busy as I am with patients and phone calls and needing to get schedules figured out, I can take 20 minutes out twice a week to talk to her, to get her calm and make her feel like she's really being good with her son, getting him what he needs, offering other services. I told her, come in to see him, bring him to treatment. Go down to the Patient and Family Resource Center. Talk to some of the ladies down there. Talk to some of the patients down there. So she called me, what is that, Friday? She called me Wednesday midday because she had to come get him some pain medicine. No, Monday midday. She had to come get him some pain medicine. And she was like, I talked to those ladies there. They were really nice. You should go down there. Why don't you meet me down there? We'll have coffee together. I told her, I said, I appreciated that, but I didn't have that time frame to do it. But for her to continue to do that, and it would help her. So there's a lot of different things that navigators can do, as well as lay navigators. What are the side effects that the patient's treatment may be causing? We try to go over that. Dr. Weiss does, then Chaely does, and then I do as well. Giving them helpful hints like keeping food on your stomach, small frequent meals, push fluids. Rule of thumb, half your body weight in ounces, which I would drown, but half your body weight in ounces of fluids to drink. That will flush the toxins out. Suck on hard candy. And then I'm the poopy queen, so if you ever get constipated, call me, I can fix you. I can also stock you up in a heartbeat too. So, you know, there are all different side effects that I try to go over with patients. Chaely does the medicine part, I do the helpful hint part. Small frequent meals, tell them about when I worked with hospice, we had poor man's Ensure that we would help patients mix up. It's a package of the powdered carnation instant breakfast drink. Mix it with whole milk, an egg beater, a little bit of vanilla, a pinch of sugar, and no, sugar is not fueling cancer cells. Now, if you have certain types of cancer, probably, but lung cancer, it does not. Mix all that together, put some Hershey syrup in there, scoop of peanut butter or fruit, whatever, and that gives you the equivalent to a can of Ensure, and you don't have that yucky taste. Plus, it's cheap, so a lot of patients like that. I have one patient who would freeze a can of Ensure, put it in a blender, and then chase it. he would drink it and then he would chase it with something else to drink. So it does have like a chemical taste to it, but poor man's Ensure really did good for him. What if you have a severe side effect outside of the office hours? A high fever, vomiting not controlled by antiemetics, constipation, and Tammy's toddy doesn't work. You know, anything like that. I usually tell them, call the on-call doctor, but if you don't get a call back in 15 to 20 minutes, call back again, because a lot of times if they get busy or if the operator can't get through to them. But don't just sit there and wait all night, wait 6 hours before you call back. However, if you have shortness of breath, you're coughing up blood, you have a bleeding wound, or you have a fever of 101 or greater, take your little butt right to the emergency room. Do not pass go, do not wait, call bugs. A lot of people will try to prevent going to the emergency room, and I understand it, but we cannot treat it outpatient like that. Pain management. We try not to give opioids out freely, because you know, it's big in the news. But I also tell patients, if you have pain, then you need to let us know so we can address it, we can evaluate it. You need to be accountable for your pain medicine. Yes, we have patients who call us and say, well, I dropped all my bottle of pills I've just picked up down the sink, or they fell on the floor and went in the toilet. I have heard it all. So we tell patients if that's the case, or if somebody stole it. If they've stolen, then you file a police report and bring us the police report, and then we will address the pain medicine then. But they need to also keep a pain log, so that way we can get the right dose that they need. So just one pill is not going to fix everybody. So tell patients that they need to keep a record when they take it, what their pain score is, how it gets, if it gets any better after an hour, and then keep a record, bring it in, and that way we can see how much they really need to be on a routine basis, but for them to protect all their pain meds. How will treatment affect my activities? We've had one patient recently who has a newborn grandchild, and she was terrified she couldn't be around them because she was getting chemo. She was afraid that the chemo would come out of her body and get into the child. So we've had to do a lot of education there that you're not going to give that baby anything. You can kiss on that baby, you can hug on that baby, it's not going to hurt them. When I told the lady that, she was beaming ear to ear. She said, I'm going to my daughter's house now. So that will affect their quality of life. Also, if they're getting a really strong treatment where they're going to be weak, or if they're already weak from their treatments, they need a blood transfusion, or if we're going to give them extra medications, extra Benadryl, to where they were going to need somebody to drive them. I always tell patients, the first time, get somebody to come with you, just sit with you, keep you company, and that way you can see how it's going to be down the road. Are you going to be able to work during treatment? We encourage patients to continue to work, but if they feel like they cannot work, if the schedule's too much, then we'll work with them and do their FMLA. Of course, with it being beach season, vacation season, patients want to travel. We have to, if a patient's on oxygen, I have to get them tested a certain way to be sure the amount of oxygen they're going to need when they fly. And also to take their medications and keep them on their person when they're traveling. And then clinical trials. When patients come in to us, we always encourage clinical trials. Like I said before, it's not Dr. Weiss locked up in the basement making stuff up. It's FDA approved things. We go over, Dr. Weiss goes over what the trials are there for and what the outcome is. And then when it comes to financial concerns or questions, we don't turn patients away. So if you have no insurance, you don't have a penny to your name, then we still take care of you. We find resources, whether it's we put them on the charity care program, we get financial assistance through the pharmacy where they can come in and pay $3 per prescription. We find, like with the grant that we were talking about earlier, the $200 grant, had a patient whose truck was totaled when he was going to dialysis in between chemo. And he was trying to find a way to pay somebody to fix his truck. truck was totaled, but he used that $200 and was able to get another used car, and he was so happy. And I meant to tell you, he thanked me on the phone the other day. He was crying. He said, I don't know what I would have done without that $200. So it makes a difference. In summary, I always tell patients to make a list of questions. Keep a notepad beside your bed. If you think of something in the middle of the night, like I do, you write it down and go back to sleep. But bring it with you when you come to see us. When you're there in your visits, you can ask the provider or nurse practitioner if you can be taped, or if you can have a FaceTime with the other family members so they can hear it too. That way you've got multiple ears hearing what we're telling them instead of just missing bits and pieces. Bring a list of medications or bring a bag of medications. That way we can make sure if you need refills. Always keep a record of your pain medicines. Don't wait until the last minute that everybody does and run out and say, I need some pain medicines at 5 o'clock on Friday. One of the biggest things that me and the navigators I work with now are trying to encourage patients to be accountable for their appointments, to be responsible for making and keeping their appointments instead of saying, well, you didn't call me or you didn't give me my appointment. I'm not a scheduler and I can barely keep up with my own appointments, so don't rely on me. Be a self-advocate. If you have questions about a treatment, do you have concerns about a side effect, if you feel like something's not right with you, be an advocate, speak up. You've got to be a self-advocate all the time. Never be ashamed to ask a question and feel like they're stupid. No question is stupid except the ones you don't ask. Again, never Google lung cancer or cancer period, because you will get, God knows everything. And take responsibility and take control over your fight with cancer, and then you will be a winner in the end. Any questions? Any comments?
We'll wait, and we'll do questions at the end.
Okay,
Yeah.
sounds good.
Questions after Susan, but we'll, that was very informational, a lot of good stuff there. Now let's hear from Susan and kind of bring it all to a personal level.
Hi, I'm Susan Kjellqvist, and I am the new development director at LCI, and I'm also a non-small cell lung cancer survivor. And as part of this role, I seem to have many opportunities now to tell my story. And the problem with this, though, is that telling your story can be an emotional experience at times. And so one idea I came up with was to write it down and read it. So I'm sorry if I'm reading it, but this is something I'm trying. So let's hope that helps. And then I'm happy to take any questions. I'm sure you'll have questions for everybody else. So, I can assure you that no one is more surprised to be standing here today talking to you than I am. Back in October 2018, I was enjoying a lovely trip to Italy, but I found that all the walking and the hills and the stairs to climb were really wearing me out quite a lot. And I knew something had to be wrong, but I was just too busy with a full-time job. I had a son in high school and one in college, so I had to keep working to fund that. And I had an elderly parent who lived far away, and I had a good deal of travel both with my job and seeing my mom in DC a lot, and I was being pulled in a lot of different directions, and I just did not have time to be sick. However, after returning home to Houston, where I was living at the time, I finally went to see a doctor and get things they sort of gave me a little ray of hope that it might not be. But that relief was short-lived because when the pathology from the fluid testing came back, it was revealed that there were cancer cells in it, and which they believed to be originating from the lung. So further testing revealed that those cells were positive for the EGFR mutation with the exon 19 deletion. And no other mutations or PD-L1 showed up, so my doctor thought I would be a good candidate for Tagrisso. And I started taking that immediately. The following month, another fluid drain and testing did not show any cancer cells in the fluid, but since I had such a large amount of fluid that would probably take some weeks or months to receive, if it ever did, I decided to go ahead with the fluorodesis procedure to eliminate it a bit more quickly, and since then my scans have been clear. So I'm now closing in on 4 years since my diagnosis, and when all this started, my doctors at MD Anderson refused to give me any definitive prognosis. So I, of course, to Tammy's point, turned to Google. And when I looked up malignant pleural effusion, I got the impression that it was something that people only got in very late stages of cancer when the person was virtually at death's door. So that was not very encouraging. One statistic had me dead in weeks to just a few months. I admit I did not take all of this well, but I did not stop there with my research. And along with all the negative information on this condition, I found a number of hopeful stories, as I know you all probably did. If you look hard enough, there are some hopeful ones out there. I also it also propelled me on a journey of trying to do a variety of things to try to heal myself in addition to taking Tagrisso. Of course, I know Tagrisso has been a lifesaver for me and for so many others, and I'm hopeful that researchers will eventually discover ways to enable Tagrisso to last longer for patients by finding methods of offsetting progression, or else discovering even more effective therapies to replace Tagrisso altogether. I just want to add that in addition to the amazing treatment I've received, I've also been blessed to receive excellent care both at MD Anderson in Houston, Texas, and now here at UNC Cancer Hospital with Dr. Weiss. In fact, it was Dr. Weiss who encouraged me when this opportunity came up to work on staff at LCI. So I'm grateful to him for believing in me that I could actually do this. Also, I want to emphasize how much I appreciate all the doctors and researchers who are devoting their lives to studying lung cancer and finding ways to help people like me live longer, healthier lives. You are making a huge difference in relieving the suffering and extending the lives of people who just a few years ago had very little hope. As Dr. Weiss said, 50 years of no progress in small cell is just amazing. So thank you so much for all that you do. I really appreciate you, and I'm so thrilled to be able to work for LCI and support you in a small way that I can. And to Tammy's other point, I'm happy to be your guinea pig. If anything promising comes up, just that is, I think that's where most of the hope lies, is in new things that are coming out and people being courageous enough to put themselves out there and try new things. That's what's gotten us as far as we have. So thank you so much. And, I'm happy to take any questions, or I'm sure you'll have questions for everyone else here. So thank you.
Yes, and I will just say that we are so excited to have Susan on staff, and now I think we might have